So now we run into the problem where you don't have the hamstring range of motion, which would look like Mike going through his bracing sequence, everything nice and tight. He has a little bend in the knees, but when he hinges forward, what happens? So start to hinge forward, and then he runs out of room, and then he feels himself wanting to bend his knees forward. And that's because you're lacking posterior chain length at the hamstring, and you need to cheat by dorsiflexing, which is okay. But here's the modifier, and here's how we're going to do our best to, it's not ideal, but do our best to avoid that from happening. So he goes through his bracing sequence, glute squeeze, inhale, exhale, tight core, pinch down and back, external rotate the hips, little squeeze, he starts to hinge his way forward. And at some point he hits motion where he cannot go any forward because if he moves forward, his tibias go up, right? So now he dorsiflexes, he cheats a little bit. He dorsiflexes a bit more. Dorsiflexes there, he grabs the barbell. And at this point, we're still braced up here, but he now reestablishes position as best he can, and then begins that deadlift hip hinge motion where you go ahead and contract and pull fully and glute squeeze at the top so that you can relax down. So the biggest difference is when he starts to hinge forward and runs out of room, he dorsiflexes a little bit, he grabs a bar, and then he reestablishes position. So he almost sits back as best he can, and it may not be a 90-degree angle from your tibia on the floor, from your shin bone on the floor, but it's as close as you're gonna get. So you're still going through, and even though it would be more natural for him, because it's hamstring deficit that we're pretending he has, to go through into a squat motion, where he comes out of that squat basically with a knee bend motion, I want you to run out of motion, establish as best you can perpendicular angles of the tibia, and then pull from there. So the biggest difference is when you run out of motion, you dorsiflex a little bit, grab the bar, reestablish that 90-degree angle as best you can, and then pull from the floor from there. So someone who's using that is the person who failed those first two tests, being the toe touch test and the long sitting test.
All right, so we figured rather than just running through and showing what it should look like, we'll actually let Dr. Tim demo, who will use that knees forward positioning to start. So we'll actually start by showing the toe touch test. He's going to kind of take you through it. Feet are under the bar. He's locked out. He's going to drop down like he's trying to touch, but as he's going, and a little hard to see with the plates blocking, but he's getting probably a good inch from the bar, which is telling us right there that is one of that first failed test. If we went through the second, we'd see the same. So he's actually going to demo what it would look like to use the knees forward positioning. So if you want to step into it, we'll get started with it.
You do the second test too.
Oh yeah, let's do it. Go ahead.
Might as well, I'm here.
Just to show the second test, the long sitting test. If you notice, yeah, Tim trying to lock the knees out, what he's going to do is pull the toes forward, and he can get in this position and lock out, but like I said, is this comfortable for you? No, this is not a position he'd be able to stay in. In fact, probably what once happened is he wants to bring his knees up just to take that slack off that entire posterior chain. So it's a second failed test, in which case we now know this knees forward position is appropriate for Tim. So as he's already talked through the whole bracing sequence, start with the glutes, go to the core. From the core, you'll lock out the shoulders, and then you'll turn on those glute leads as well as you lock out. And he's dropping down like he's going to get the bar, making sure his head stays in the right position. When he gets down there, he runs out of room. So what you're going to see is ankle dorsiflexion, probably seen for you by knee flexion to let him get to the bar. Now that he is at it, he will lock back. You hear him create maximal amount of torque as he grabs onto the bar. That's that click, and then he brings it up, comes up, locks out at the hips, then brings it back down appropriately.
So from a mobility standpoint, we talked about what you're lacking from a positional standpoint is posterior chain length, so we can change that. And there are different mobility techniques that run parallel to one another, one being tissue length, the other being tissue health. Tissue health is like, if you think of healthy tissue being silly putty that you can stretch statically, and pull apart and lengthen the tissue, while unhealthy tissue being like trigger points or knot spots that are tender inside the muscle that you want to foam roll, being marbles. Then you can grab the tissue, you can stretch it apart. But if those trigger points are inside the muscle, that contracted tissue that's irritated, where something like our techniques like dry needling or active release technique would help, sometimes you can do positional mobilizations to release that soft tissue. And so you were looking for, which is kind of like a neurological sensation. The idea behind manual therapy has changed for sure, but it's a neurological release. So you're looking for these hot spots in the muscle. So it's kind of tough to foam roll your hamstrings. If you're sitting on a foam roller, a lot of times you can't get in depth. So using like some sort of ball in a seated position can be really helpful, where Mike will use this ball, flip it on the hamstring, and he kind of knows where that tender spot is. He'll kind of search for it to some degree. And when he finds that tender spot, all he's going to do is he's going to lean into it, and he's going to extend and flex his knee back and forth over that tender spot. What should happen is that area should get less tender over time. again, if your patient is having pain, then you need to, or your client, and you're not a healthcare provider, they need to be referred out. If they're just tight, a lot of times you get away with doing some of these positional mobilizations. So you're going through for maybe 60 seconds, 10 to 15 deep breaths, and that area should get less tender over time. If it gets more tender, then you're pushing too hard. And the mobility should change afterwards. It should get harder to find those tender spots, those trigger points over time. If it gets easier, then you're pushing too hard and irritating the tissue. Usually good to be done before and after you exercise type of thing, to just hunt for those spots. Number 2 is a barbell mobilization, which we don't have the setup here, but if this guy was raised up on a squat rack, or you can see a picture of it being in a position on my paper here. Here you go. Thanks. Page 3, where you can see the rack pull, where the bar is elevated on the rack. Then you could sit on that bar, same thing as a lacrosse ball, pin down a tension on the hamstring, and then flex and extend at the knee as well. And that would be another idea if you don't have a lacrosse ball in your toolkit, while you're at the gym. So that is tissue health. This is tissue length. So tissue length is a 3-movement technique where Mike is going to go and he can do the low back first, where he'll attempt to reach for his toes. If he'll tension open his hamstrings. When he feels that tension develop, he will wing his legs to the outside. So you're kind of like sit like a frog. And at that point, he should feel more in his low back. So he's going to cross his hands across his chest. He's going to flex down towards his hips, and he's going to rotate either to the left or to the right. And you should feel a stretch into his low back. If you still feel it in your hamstrings, then you need to bend your legs a little bit more. If you don't feel a stretch at all, then you don't need to be doing it. But there should be a stretch in the low back. He's going to hold a static stretch for at least 18 seconds, but probably 30 seconds in case you're a fast counter. But 18 seconds makes a permanent change. So that's the first one of the toe touch sequence. Number 2 is Mike is going to stand up, and he's going to prop his feet up on here, his toes up on here, and he's going to take this ball, put it between his knees, and then give it a squeeze for those adductors to turn on. So we'll prop the ball through there. He gives a squeeze through there to turn on the adductors and the quads to some degree. Then all he's going to do is hinge forward and attempt a toe touch. And what he should feel is probably a stretch into his calves. So we're doing a couple things here. We have these plates on the ground, which are elevating his toes up, and that is biasing a stretch into the gastroc and soleus complex that will limit dorsiflexion, which can be a problem with this. When he's squeezing that ball, we're using the idea of reciprocal inhibition. And reciprocal inhibition is we're turning on a agonist muscle to relax an antagonist. So when you're turning on adductors and quads and doing the toe touch, his hamstrings and calves are relaxing out automatically on that posterior chain, which allows him to get more depth. Maybe he's holding for a couple seconds and he's going through that motion. He will then flip around and face me, in which his heels are not elevated. The ball will still go between his knees, and he will turn on those adductors and quads by squeezing as hard as he can, and then he will attempt a toe touch. And where the difference here will be is we've now taken the calves out of it, and he's now feeling this in his hamstrings. So we have a low back tissue length, gastroc soleus complex tissue length, and then a hamstring tissue length to finish it off. You should always do the soft tissue work before you do the static stretching to make a difference. The last portion of this on the last page are the accessory lifts. The mobilizations are increase your range of motion. The accessory lifts either serve 2 purposes. They are either to make you better at the lift in your sport, or they are to build the armor in terms of muscle hypertrophy. So the first one is the rack pull on your sheet. And the rack pull, the bar is elevated up to a sticking point. So if I'm the type of person, every time I deadlift, I get stuck right here in trouble with my lockout, then I would raise the bar to this position and I would start pulling from my sticking point. So that is more performance enhancing. You will gain strength from that, you'll gain power from that, you'll get better at the deadlift, but you're working on that deficit of your sticking point. This is also a great technique for someone who has very poor hamstring range of motion, so make note of that. If you have someone who you're trying to train posterior chain, but they're not a barbell athlete, they're a sprinter, long jumper, something along those lines, basketball player, and they have a really, really poor toe touch and they fail those hamstring tests, you don't have to have them cheat the motion. You could train the deadlift, or you could train the posterior chain by just doing rack pulls where they don't have to bend as far, but they still get that posterior chain activation, and it's along the same vein. The second one is the RDL, the Romanian deadlift, where you're starting in a upright position through here, you're turning on those muscles and you're slowly lowering until you feel it pull into your hamstring and then coming back to a neutral position. This is more hypertrophy because it's time under tension. And again, these are more important to understand the why behind them as opposed to understanding like, I need you to be able to do these techniques right away, because the deadlift carries over to all of them. But the RDL is a great technique where you have more time under tension at the hamstring and a loading. And that time under tension creates hypertrophy of that posterior chain and is preventative from a tendon structure injury or from a hamstring pull injury standpoint. The last one is the deficit deadlift on your sheet. And this one, the athlete is seen standing on a bar, and hopefully this is not their ending position because they're really dorsiflexed, but standing on a plate, I should say. Standing on the plate, they are now working with an athlete who maybe has trouble coming off the ground. So if you have trouble initially pulling out of the hole, but you can lock out anything, the deficit deadlift is a great thing to do. If you think about this, who would this be bad for? Someone with really poor hamstring range of motion. Because if I don't have the motion to reach to the floor, then obviously I don't want to stand on a plate and go through an attempt to, move the weight in that manner as well. So those three are just options. If we're covering this data or this information on the lab practical portion that will be written to some degree this semester, and we'll cover that, moving forward. Then it doesn't have to be one of these tests. You just have to be able to justify your answer. You could give me, a kettlebell swing, a single leg RDL, Bulgarian split squat, anything along that same vein. But as long as you're able to justify why you're doing it, then I'm okay with it. These are just three options that fall into either a performance enhancing category or a hypertrophy category, which is preventative. It's armor building. Building up those muscles from a stability and strength and hypertrophy standpoint to avoid the pounding from running, getting hit by a linebacker, anything that's considered trauma to the body. So we will end lab here. Get closed caption adding this material to you. If you have questions, reach out to us via our university emails. And thanks, guys.